5 minutes perhaps.
Thank you.
Thank you, Mr. Chairman. Dear colleagues, ladies and gentlemen, I am honored to make this presentation with my friend, Professor Michel Daher from Lebanon. There are no conflicts of interest avec this presentation. It didn't escape you. My English is marred by a terrible French accent. Donc, forgive me. No. Now, ethical issues of breast cancer management. We proposed the following plan. Part 1, introduction. Part 2, ethical issues in the management of breast cancer. You can see here that there are several situations. Then part 3, conclusions. Introduction. The management of breast cancer must be interpreted, disclosed, and carried out respecting the ethical principles of, there is 4 principles. Beneficence, non-malfeasance, autonomy, and justice, while respecting the cultural difference of the other, its human dignity, and its personal integrity. Ethics is an ongoing questioning based on human dignity. Ethics is questioning that's always renewed and inevitable, far from being ready to think or ready to act. Ethical questioning has never left humanity, because questioning is looking for the right road. That's very important for me. You know that breast cancer in the world, it is a true public health problem. First women cancer in both developed and developing countries. Management of breast cancer. There is 2 levels. 2 elements. First of all, urgency. Second, primordial. Urgency to develop effective and affordable approaches in the world's poorest countries. Early detection, diagnosis, treatment, and primordial. Primordial to reduce morbidity and mortality. Take advantage of the experience and progress made in recent years in developed countries. Now, look at that. This is the wheel of a global care conception of breast cancer care. It's a logical continuation parallel to the natural history of breast cancer. You see that prevention, screening, early diagnosis, diagnostic and treatment, palliative care. The center of all of this is a national and international mobilization. We have also the channels that feed this wheel. We have laws, we have research and training, we have social support, and we have communication. You see, communication, it's a part of breast cancer care. It isn't a supplement. Donc, first of all, now, we will talk about ethical issues in the management of breast cancer. First of all, screening and early diagnosis of breast cancer. Screening is one of the stages of care that raises many ethical questions. Early diagnosis, to recognize, you know that, all of you, to recognize the first signs and symptoms, to facilitate the diagnosis, and to institute a curative treatment at lower cost. Ethical discussion about the usefulness of an organized breast cancer screening program. It's about its efficacy, its difficulties, its limits and controversies, its side effects, its economic consequence. There is also a confusion between screening and prevention. It's necessary that women are, we shall not prohibit screening. We shall not stop screening. It's necessary that women are properly informed of this reality. The aim is not to stop screening mammograms, but to explain it clearly. Self-examination of breasts remain essential and recommended to sensitize women. Ensuite, second, inequalities in the treatment of cancer. I will go quickly now. The Universal Declaration of Human Rights, 1948, states that every individual has the right to a standard level of health and well-being for himself and his family. Inequalities in medical care is the best indicator of general inequalities in a society. People of low socioeconomic status have a higher incidence of cancer and a lower survival after diagnosis. Developing countries have lower survival rates. Lack of education, organizational deficiencies in management of breast cancer, limitation of resource, cultural constraints. In developed countries, there is two strategies. Early diagnosis strategy, clinical examination, mammography, pathology examination, and therapeutic strategy. The treatment of breast cancer is based on surgery, radiotherapy, chemotherapy, including targeted therapies, immunotherapies, and hormonotherapy. Indication of the different therapeutic, that's very important. The different therapeutic modalities are discussed in multidisciplinary consultation meeting. Third, the breast care model. There is no universal model. Every country has to create its breast care model. Create it according to the medical infrastructure, the social, economic, and cultural realities. The subject precisely touch on ethics here. 4, the announcement of breast cancer. The high incidence of breast cancer and progress in its diagnosis has created a new imperative for caregivers, us. Learning to talk to patients, learning to talk about cancer, learning to talk to the patient about his cancer. That's very important. The announcement of breast cancer is often very destabilizing. The reaction is often depending on how you make the announcement. Stunning, denial, distraction, avoidance, revolt, bargaining, state of depression, state of sadness, acceptance, resignation, sublimation. Sometimes the psychological effect can be more ambiguous. Delirium, confusion. The announcement of breast cancer is a real definitive break with the previous life. The announcement of breast cancer, if law requires us to inform the patient in a loyal, clear manner, ethics recommend us to manage his distress of the patient. And empathy that we need, my friend. Michel.
Good morning, and thank you, Mr. Dr. Yasser, for your kind introduction. I would like to thank also Dr. Anas for giving me the opportunity to talk to you about an ethical issue very important in breast cancer and other cancer, which is palliative care. So what have we learned from the experience, international experience, is that 40% of cancer can be prevented by non-smoking, by a good diet, and by some vaccination of some infectious diseases. 40% of cancer can be detected early and cured by screening or by other way like prostate cancer, like breast cancer and others. And the remaining 20% can beneficiate from palliative care to have a good end-of-life care. So what is palliative care? Palliative care is defined by the WHO as an approach that improves the quality of life of patients, and of course, supporting the family that is all the time around the patient, and to prevent the suffering, and of course, supporting the patient from all ways at the physical, psychological, and spiritual situation. In summary, it is a way to prevent suffering for these patients and to have a good quality of life and a good death, and at any time and whatever is the diagnosis, not only in cancer, it can be adapted to some other diseases like cardiorespiratory, neurological, and other situations. The end point of palliative care is to have a live better and live longer. We will see that palliative care is not shortening the life, is prolonging the life in some ways and in good quality of life, and it adds life to days and days to life. This by providing to our patients to eat well, sleep well, maintain his function, to be independent, and of course, reducing the stress of the patient with a very life-threatening disease. Here are the key principles of palliative care. It provides relief from pain. It regards dying as a normal process, and this is very important in our region, where it is a taboo to talk about death. It does not hasten the death. Some people can understand this. Of course, it provides a good quality of life, and of course, it's a person-centered disease and focus on the whole person, and it integrates the psychological and spiritual aspect of the patient care. And of course, the family is essential to be supported in this program of palliative care. The domains of care in palliative care is a whole problem. It starts by physical for pain control, psychological, social, because these patients who are approaching end of life need some support for their social and spiritual situation. And of course, the end-of-life management can be held by the team of palliative care. And of course, the disease management as a whole is the objective of palliative care. It must be given by a multidisciplinary team and interdisciplinary team. As you see here, we have so many people around this patient at the end of life. The nurse, the doctor, spiritual counseling, psychological, pharmacist, physiotherapist, social worker, and many others who can help in supporting this patient. And the historical perspective of palliative care was in this way. The anti-disease therapy takes place all the time before the last 6 months before death. And this was an idea to continue sometimes chemotherapy, although it is helpless and it is not of good interest. And now, today, the palliative care is starting very early, as soon as we have the diagnosis of an incurable disease. So we have the anti-disease therapy. We call it transforming the natural history of disease, and in the same time, starting palliative care by this multidisciplinary team so that we can prevent pain, we can give comfort to the patient, prepare him for the death, and having a better quality of life, better quality of death, and help this patient in the bereavement care, which is with the family most of the time. So, a study in 2010, a very important study on lung cancer, where we have two arms. One arm was we start palliative care very early in the diagnosis of disease, and we have the natural history of the disease with the regular treatment, with the conventional treatment. And we saw at the end that the patient with early palliative care have a longer and better survival, have less IV chemotherapy at the end of life. They have an improved quality of life and a mood, less pain, fewer readmissions in the hospital, and an easier bereavement. So, concerning ethical issues at the end of life, it is very important to balance between benefit and burden. Benefit of prolonging the life of a person, and at the same time, the burden of such prolonging life, as for suffering, as for independency, as for isolation, as for immobility and dependence from other people. So if we ask all people who are here, how do you want to have an end of life? I'm sure that you will choose the desires of any persons who would like to die not on a ventilator, not on a machine. You would like to die in comfort, without pain. You would like to die with your family, with your friends, at home, in your room. And of course, these are not given to all people at the end of life. So we have always to think about this, the burden and the benefit of living the end of life. So the ethical issues and dilemmas that we can have at this part of life is, first, when we have to withhold or to withdraw a treatment. When we institute a futile treatment, it is very difficult then to withhold or to withdraw a treatment. So we have to choose before if we have to do a treatment or not. Two, do not attempt resuscitation. You know that in the hospital we might give DNR order, so it is not now do not DNR, it is a low normal death. We should know when and how to give a normal death for our patients and not go in a futile treatment. And of course, aggressive treatment sometimes can lead to the last syndrome. When we give high dose of pain management, the patient might die. So please, would you like to... So in the assisted suicide and euthanasia, in our countries, it is forbidden. Euthanasia and assisted suicide are forbidden, but we know that if we have a good palliative care services, we can avoid many cases of discussion about these two situations, because palliative care will put the patient in a good condition and he will not ask for assisted suicide or for euthanasia. As a conclusion, the management of breast cancer, it is in the line of Hippocratic concept of care. Two, it is not a supplement. The ethical aspect at the end of life should be taken into consideration. And of course, we need ethics at all moments of patients along their disease, even when it is an incurable disease. And at last, I would like to introduce to do these two photos of my friend Anas chosen them. The GREM, we had an annual meeting in 2008. It was in Morocco, Rabat. And lately, in March 2019, it was in Lebanon, the meeting of GREM. And I thank you very much for your attention.